Thank you, everyone. It's my pleasure to be here. I apologize that I needed to change for family obligations. I was having this discussion yesterday with Haitham when I had the first the first talk was about pocket infection, how to prevent, and then when I knew that Dr. Mohamed Magdi is not coming, I thought I may add a little bit of a small talk about leadless pacemakers as well. أنا اسمي محمد المغاوري. For those who don't know me, أنا شغال في مكانين، في معهد القلب وفي مستشفى الناس، وقبل كده كنت شغال في مجدي يعقوب. مين يعرف ده؟ إجنس سمر لويس. طيب ده راجل مهم جدا بالمناسبة. هو أول واحد قال للدكاترة إن هم يغسلوا إيديهم. أوكي؟ فهو إجنس كان دكتور obstetrician. He lived in Hungary في المملكة المجرية in an era before Louis Pasteur. At that time the germ theory as a theory was not completely there. فهو الراجل بتاع obstetrics. فكانت الستات حوالي وقتها كان البيريبارتم sepsis وانفكشن كان around 20%. فقلت طب ما انا اجي يوم كده اغسل ايديا اشوف اللي هيحصل. in 1 year's time الانفكشن عنده قل من 20% ل 3%. فانبسط فقرر ان هو ينشر كلامه. فراح بقى الاكرا بتاعه الاوبستريشنز في هنغري، قال لهم يا جماعه ممكن تسمعوا كلامي وتغسلوا ايديكم. قالوا لكم مش هطلع بره، انت بتقول كلام فارغ. فعاد الكلام مره ثانيه، قال لهم مش هطلع بره، انت بتقول كلام فارغ. up to ان الراجل ده at the end سوري ايوه بالظبط هو في الاخر اتجنن and then he died يعني in an institute of an asylum, a psychiatric asylum. He was the martyr for infection control. I work in my place in Al Nas Hospital, and I work in other places. If I see a crazy, angry person in a place, and I ask who is this, and they tell me that he's the infection control management, I feel safe. So the most hated person in any institute should be the infection control representative. If you go to another place and they don't have infection control manager, or that he's a happy person, you see him happy and he's relaxed and smiling and everyone is friends with him, know that you're in a dangerous place. So at least in 2 places that I worked in, مجدي يعقوب وفي الناس, these are the people that we don't say hello to in the morning. والمعهد تمام طبعا. بس يعني at least في المكانين دول احنا our infection rates we take them seriously. And I think this is the idea. It's not about what to do and what not to do. It's about creating the culture. And عشان كده كانت my presentation would have been very short about create the culture for infection control prevention. And this has to be reinforced. If you go and work, and I'm talking to my younger colleagues, if you go and work in another place, like a different place than your usual place, listen to what they tell you and see what they're doing and just follow the protocol if the protocol works. You don't have to reinvent the wheel. It's just simple measures. You need to check the cath lab infrastructure. You have to educate the personnel. You have to have some pre-procedure preparation for the patient. You have to educate the patient. You have, of course, to have sterile environments and wise use of antibiotics. So, for example, before you start the procedure, you have to identify high-risk patients, as Dr. Naeem has mentioned. If you're having a battery exchange, that really increases the risk of pocket infection. If you're doing a redo procedure or third redo procedure, if this is your first case of left bundle pacing, or if it's a complex CRT after a failed CRT, you know that this is going to be a long procedure. This is a high-risk patient. If you have a diabetic patient, an elderly, and so on and so forth, if you know a patient who has for example, immunocompromised, he's on cortisol, all of these, it really increases the risk of device infection. One thing that I learned in Aswan, I used to work in Aswan, it's a very hot, it's not very humid, but it's a very hot place, is that our rates of infections double in summertime. So if you have a patient, let's say for example, patient who's having a battery exchange, and you know that the battery will end in 4 months' time, and you see him in March, do him in March, April, at least in Egypt. Do them in March, April. Don't wait to August. This is something that we do, and this has really reduced our risk of infections. What we do in Al Nas Hospital is that we do nasal and groin swabs for multi-drug resistant organisms. Again, this is hospital protocol. Every hospital can have a different protocol. We don't have to stick one single protocol. We also do some chlorhexidine showers. What we do in Al-Nas, again, this is you follow whatever the antibiotic protocol for each hospital is, that we give 1 ampoule of vancomycin, then we start cefazoline half an hour before the procedure. What we do also is that we try to minimize the flow of personnel in the cath lab. So we have a single entry, single exit door, and we keep that door shut. We minimize the number of personnel inside the cath lab. And for the ladies with the hijab, we usually ask my colleagues to change the hijab with a different hijab just for the procedure. So it's not the same hijab that she's wearing in the street. Afan? Oh. No. Yes. Yes, of course. Yeah. No, come on.
Women or men from scrubbing with me. I told Salah and Alfie, you are the nurse, you are the assistant. And if I don't allow nurses, men or male or females, to scrub with me in any device.
Yes.
At Dar al-Fuad, the highest level of. Because I see them with their stretch, making.
This is the type of attitude that we want the infection control managers to have. They have to be sharp, they have to be angry, and they have to be aggressive and right.
لا صح. لابسين ايه؟
مظبوط. فندم؟ الراجل متجنن في الاخر يعني.
هحصله.
طيب حاجه take your time. We're not in a race. And I'm talking to the young colleagues. Everyone in my young colleagues think, okay, I finished my pacemaker in 15 minutes. I finished my patient 20 minutes. We're not in a race. What we need to do is take your time. Do proper hemostasis, because hematomas equal infection. If you can use monofilamentous sutures rather than polyfilamentous sutures, meaning monocryl instead of vicryl, proline instead of silk. I don't wash the wound. I don't give gentamicin. This is what the guidelines say. Try to minimize the hospital stay as possible. So if I have a post-operative patient, I would do that right before he leaves the ICU. Of course, there should be no central lines. There should not be any urinary catheters or any other interventions that will be done. So the last thing that you should do for a patient is to put the pacemaker, and then he can go home. This is as in a perfect world. Every place has their own way of wound dressing, or the frequency of the wound dressing. What I usually do, I personally, is I ask the patient to do the wound dressing on himself every day. That's what I do. However, I know Haitham, for example, puts the wound, and he asks them not to change it. I know Dr. Mervet does this, and Masan, but and the Multi does the same. So what I do is that if I go to a place that, let's say, for example, I go to a place that you work in, and you work in there more frequently, I tell them, do whatever Professor Badran does. I tell them, do whatever Professor Mervet does, do whatever Professor Damati does, because they are the people who has done that many times. The nurses know what to do, and they follow, and we have by experience, by numbers, and that's you have to be humble and to understand, like, أنا بتكلم عن نفسي, and I have to understand that this, whomever person's protocol works for that place, keep it as it is. That includes the antibiotics regimen that should be given later. We have for reinfections the Tyrix. However, I'm not a big fan of. The results are, and Dr. Naeem, I think, believes the exact thing. There's a big promotion for the Tyrix envelopes, but I don't see magnificent results from it, and also the literature does not really enforce that its use. It's quite expensive.
It's one study. So the rapid study, it's only one study. It's sponsored by the company, by Medtronic, and they chose, or they recommend to use it in especially in box exchange in high energy device, ICD or CRTD. But I mean, it's not for routine use. I think it's not available in Egypt.
Yeah.
How much? If they can give for free with the device.
Anna, my time has finished. Do you want me to give 2 minutes for the leadless pacemaker? So that leads us to the next thing, which is I'll just briefly show like what we do in Al-Nas Hospital in terms of with our pacemaker, leadless pacemaker experience. We have done 10 cases so far. 8 of them are actually like this man. This has been recently sent by one of our dear professors. The dear professor is not the main implanter, but this man had an infection on the right side, on the left side after complete heart block with the pacemaker. 6 months later, infection, and then had another implantation on the right side, and he presented to our clinic like that. So I admitted the man, and we implanted the leadless pacemaker for him. So a leadless pacemaker, we in Al-Nas Hospital will implant the Micra, but soon in Egypt the Avera will also be available. I think between the Micra and the Avera, I think the Avera has an important advantage or edge, which is that it can be screwed out and it can be extractable. However, the Micra is not extractable. It is extractable in theory, but it can be very, very difficult. So if you put in a Micra, you know that it will be there to stay, and if the patient needs another one, then this will need to be put next to it. So they usually put 2, you will end up only be able to put 2 devices for العيان. You cannot put more. So what are the clinical needs? Are the lead complications, dislodgement, installation break, connector issues, venous thrombosis, or pocket complications, which is the main reason. Now we have implanted 10 cases so far. 8 of them were due to bilateral pocket infection. Only 2 were related to other issues like a dwelling catheter for cancer or whatever. Or pocket complications related to Twiddler syndrome or aesthetic concerns of the patient. But however, again, we do not till now advise, and I think Dr. Naeem agrees with me, we do not advise to put a leadless pacemaker for aesthetic reasons in younger population, because if you use the Micra, you'll end up with only 2 Micras in a lifetime, maybe 3. And the second reason is because even with the Micra AV, which is that synchronizes the atrium, you cannot really, it does not synchronize after a heart rate of 100. So if you have a young person, it's not the best device for. So this is the Micra. It's exactly the same device. Either it's for the AV or the VR. And I'll just show you quickly. This is how the handle looks like, and it's quite simple in the sense that it's kind of like a temporary pacemaker implantation. However, it's a big sheath. It's 26 French sheath, so you have to be careful with the advancement. And what we aim for is this area, which is close to the septum, mid-septum. Oh, sorry, it is in the mid-septum rather than the apex, and usually the programming, we should aim for an R wave more than 5 millivolt and an impedance from 400 to 1500, and a threshold, and this is very important, a threshold that is less than 1 volt in order to maintain device longevity. I'll stop here because of time, and thank you very much.
Thank you, Mohamed.